Today we will be talking about assessment of fetal well-being, and we will specifically be looking at antepartal testing that we can do. So, assessment of fetal well-being, how do we do that in the antepartal period? Well, there are multiple tests that we can do for, it seems like, a gazillion and 10 reasons. And your textbooks and the articles that we have list those out. There are a ton of reasons. But these are the tests that we do, starting from probably the simplest to the most complex. Fetal kick counts, and we're going to be going through all of these. Fetal kick counts, contraction stress tests, non-stress tests, biophysical profiles, ultrasonography, and Doppler flow studies. And that's what we're going to be talking about in what I hope will be a fairly quick lecture. So fetal kick counts have been studied now for over 40 years. ACOG, believe it or not, does not recommend formal fetal kick counts for women who are not at risk for fetal hypoxia. And this is basically because there's no good inter-rater reliability. Women sometimes don't do it consistently, or they aren't sure what they're feeling, or it's very difficult to study this in a way that is consistent, and it hasn't really been shown to be consistent. So, what is fetal kick counts? The research has not determined the best way to do it, but the most common method is the count to 10 method, where you have the woman focus on fetal movement and time how long it takes her to feel 10. When I tell women to do this, I have them pick the time of day that they most often feel the baby move, which typically seems to be in the evening after they've eaten dinner, or right before or right when they lay down to go to bed at night. And I have them write on a piece of paper, or have a piece of paper by the bedside, so they can just say, okay, Monday it took me 10 minutes, and Tuesday it took me 30 minutes. And so that over time they can say, on average, it takes me X amount of time to get my 10. If at any point it ever takes her longer than 2 hours, she needs to call her provider and come in for a non-stress test or further monitoring. And that's it. That's what fetal kick counts are. Nothing more, nothing less. And actually, before I go on here, I probably should say that I feel like probably more than anything, what fetal kick counts do is they just keep a woman in tune with what's happening with her baby. Because I do think what happens is, in a busy day or in a busy time, women just kind of tune out what's happening. And so it's a way of just having them pause, slow down, and check in with the baby. And so if nothing else, I think it's good for that. Whether or not it really does give us the information that we need to know how well or this baby is doing, I think that's where the research is a little bit more debatable. But it is a good way for the women just to sit down and pause, and then if something is going on, it helps to get them in for us to be able then to do the more diagnostic testing that we can do with the other methods that we have. So contraction stress test was the very first antenatal test that we ever had, and the thought or the physiology is that when we have contractions, we know that blood flow is decreased to the placenta. The uterus contracts, and so that decreases blood flow to the placenta, which then leads to decreased oxygen for the baby. And so if a baby is compromised, then it will respond with late decelerations, which then we know tells us that this baby is in trouble. So that was the physiology and the thought process behind doing these contraction stress tests. So how do we do them? Contractions can be elicited by either doing nipple stimulation, which is called a breast stimulation test, or a BST, or by doing an oxytocin with using Pitocin. So you can administer it through an IV with the oxytocin, or if they're doing the BST, the woman will massage one nipple for 2 minutes and then rest for 5, and then massage the other nipple for 2 minutes, rest for 5. She should not stimulate the nipple if she is having a contraction. They typically, the research shows, work the same as far as giving us the same outcomes. However, the breast stimulation test has been shown to give more hyperstimulation So that's just knowledge for you. Results are based on a 10-minute strip. So we look at a 10-minute strip that has at least 3 contractions. So once you get 3 contractions, you look at how that baby is doing. And if you see no late decelerations, then you have a negative contraction stress test. And you want that. You want a negative contraction stress test. If you have a positive contraction stress test, that is a bad thing. And that would mean you saw a late deceleration within that 10-minute strip that had 3 contractions. And so a late deceleration would be a positive result with 50% of the uterine contractions. So this test has the lowest false negative rate between the NST and the biophysical, but has the highest false positive rate, which means that oftentimes we have really good babies in there, but for whatever reason we saw lates. I don't know, maybe the baby was having a bad day, or for whatever reason that was interpreter error or whatever. And so then we went on and did all these interventions, ended up with a C-section that would necessarily need to happen. So due to the high false positive rate and the very expensive cost, so think about the cost of nursing care, of the IV, of the Pitocin, of the monitoring, on and on and on. This has mostly been replaced by doing a combination of non-stress tests and biophysical profiles. So it's rare. I can't even remember the last time I saw a contraction stress test, or even, I'm not sure I've ever even ordered one in my career. So non-stress test, I feel like we do all the time, every day. I feel like I do these all the time. It is the most common method of antenatal testing. False negative rates range from 0.3% to 0.65%. The women should be placed when you're doing them in a sideline semi-recumbent position. And I say this, and I'm putting this in this lecture because I don't know how many of you have been in clinical where in your clinics where they are doing NSTs. How many of them are sitting in a chair or in a lazy boy and not lying on the side in a semi-recumbent position? And I just want you to think about that, because that does alter the results, possibly. So if she can be in a lazy boy, but she's supposed to be in a sideline semi-recumbent position. And so that can alter, and I know it has, I have been in situations where it has changed the results. So just to note that for a true stress test, she is supposed to be in a sideline semi-recumbent position. The test is achieved when the baby has 2 accelerations in a 20-minute window. And I have a picture of what a beautiful NST, reactive NST, looks like. And this comes right from the article that I posted this week. So you can look at this a little bit more closely in that article as well. So this is not anything different that you already haven't read. So the biophysical profile is actually a combination of your ultrasound and an NST, and this has been studied extensively for a long period of time, so we feel very, very confident with the biophysical profile and the information that it gives us. It has, and this is a quote right out of Varney, it has a lower false negative rate than the contraction stress test at 0.08%, and fewer false positive results, 60%, when compared to NST or contraction stress tests. So the total points that someone can get is 10. They get 2 points for a reactive NST and then 8 points total for the ultrasound. And here's how the ultrasound points are broken down. So there's 5 parameters that are assessed on the ultrasound. The fetus is given a 2 or a 0. They're not given a 1. It's either a 2 or a 0 for each of these 5 parameters. So they get 2 points for fetal breathing. So fetal breathing movements are counted in that 30-minute period, and if the baby is breathing, they get 2 points. If there's no breathing noticed, they get 0 points. Then they look at movement, so they're observing the limb and the trunk movements in that 30-minute period, and if the baby doesn't move at all, they get 0 points. If they do move, they get 2 points. And then they look at tone, so they're observing extension or flexion of the spine, opening or closing of a hand, and if they see that, they get the 2 points. And then they're also looking at the AFI, or the volume, and they must have a pocket of amniotic fluid measuring more than a centimeter in vertical diameter. And then, and if they see that, so the AFI is really important, then they get the full 2 points. And then the NST, if they have a reactive NST, they get 2 points as well. So when the ultrasound comes to you, you'll see it, they get an 8 out of 8 is the report that you'll get. And then you'll put her on the NST, and then if you give her a reactive NST, she'll get another 2 points. So she'll get, so the initial points you get is 8, and then you'll add another 2 after you do the NST for a 10. And so sometimes in practice, you'll have a woman come on different days, like she'll come one day for the biophysical profile and then 2 days later for the NST, depending on why you're doing the antenatal testing, because it gives you a little bit more reassurance that, so on Tuesday this baby's doing well, so you know for a whole week you've got till the biophysical lasts for about a week, and then if you do another non-stress test on Friday, that gives you a little bit more reassurance through the weekend. So if you do it kind of twice weekly, they call that antenatal testing. The research is supportive that that is a good way and more reassuring in some cases, that that's the better way to do antenatal testing rather than doing it all on one day. So that is how a lot of practices will set up their antenatal testing. Ultrasound indications. So we'll do ultrasounds for, again, thousands of reasons, it feels like. In the first trimester, we can do an ultrasound to date a pregnancy or confirm a pregnancy, maybe because somebody is bleeding, whether it's because of an ectopic, sometimes a subchorionic hemorrhage. There's many reasons why women might be bleeding in early pregnancy, but maybe to determine why. Because of pain, maybe there's a discrepancy between the size of the uterus and the dates that she's having. So maybe because she has twins, or there's a pelvic mass, or a fibroid, or some type of uterine abnormality. Might maybe do the nuchal translucency or a fetal anomaly screen, or because we're suspecting gestational tropoblastic disease. In the second and third trimester, there's numerous reasons and indications, and both either maternal or fetal, and your textbooks in Williams and Varney have tables listed in the readings of what those indications might be, and I'll refer you to that. So the ultrasound uses sound waves to reflect the images back of the fetus, and we don't want to do more ultrasounds than need be. The FDA does not condone those keepsake ultrasounds because of something called the ALARA principle, which stands for as low as reasonably achievable. Because we've seen in research that in mice that are prolonged to exposure, or that are exposed to prolonged ultrasound waves, they actually show potential issues with brain cell migration. So there's been no zero issues or outcomes have been identified in humans. So there's been no issues whatsoever ever in humans. So I just want to be really, really clear with that. But we are really, really good at making sure that we don't expose humans to too much ultrasound technology for too long. So we've got to be really careful and really mindful of that. So we don't want to just keep doing ultrasounds just because it makes us feel better. We want to make sure that we have really good reasons and the research to back up the reasons that we're doing it, and really be mindful of that ALARA principle. Doppler flow studies. So this is the measure of the blood flow in the umbilical artery, the middle cerebral artery, and the ductus venosus. We typically, I think most ultrasound techs will, they'll flick on the flow when they're looking at the umbilical cord and measure it. But we really are really mindful of this when we're looking at growth restricted fetuses. And the evidence points to Doppler flow studies being predictive of the adverse outcomes in our growth restricted cases. So the diastolic ratio, or the SD ratio of the artery, starts at 4.0 at 20 weeks, and it goes all the way down to 2 at term. And the number I always remember, because it's easy, is that it's 3 at 30. So it's opposite. So it's 4 So if you think about it, I don't know how your brain works, but it's 4 at 20, and then it's opposite, 2 at 40, and then at 3 at 30 is how it should be. And it's considered abnormal if the SD ratio is above the 95th percentile for gestational age. And your ultrasound report should have, ours usually comes in where it will tell you if it's abnormal or not, but it tells you what the SD ratio is, and it will tell you if it's abnormal or not. And in extreme cases, diastolic flow will actually either reverse or become absent. So we really do monitor this carefully, especially when we start seeing like that head and abdominal circumference in those babies start becoming abnormal. So something that you really do want to be watching. So that is, I put my reference list here, and basically they're from your readings from this week. I'm just kind of highlighting what we talked about this week or read this week in the readings. That really made sense, what you read this week. But this is just kind of highlighting these pieces. I hope this helped clarify some of the pieces. And if you do have any questions, as always, please post them in the general forum. I think that's all I have left to say. I hope you guys have a great week, and as always, take care.